Hello and welcome to another episode of the Massage Matters podcast with me, Matt Scarsbrook, and Anna Maria Mazzieri. If you haven't yet subscribed to the podcast, then do so right now. Stop the podcast, subscribe, then come back. In fact, stop the podcast, subscribe, and leave us a review because this episode is going to be epic. So you can leave a 5-star review in advance. Once you've done all that, come back, press play, and we'll crack on. So thanks for joining us for another session. Today, we are going to discuss the term treatment. We often use the word treatment, particularly around in massage. We sell massage treatments. You can go to a spa and get a massage treatment. But what does that really mean? And particularly, what does that mean when we're working with someone in pain? Now, we've been really fortunate today to discuss this topic with someone who is very eloquent when it comes to talking multimodal approaches to therapy and potentially what treatment is. Ben Cormack, thank you very much for joining us.
Yeah, eloquent is an interesting term. Eloquent in my charming Cockney accent. Maybe some people would probably hear it and say that doesn't fit their perception of eloquent, but I'm just going to take it and run with it because I'm fine with that.
Ah, excellent. All right. Well, for those of you listening who haven't come across Ben Cormack before, Ben is a musculoskeletal therapist with a clinical background in sports therapy, rehabilitation, pain science, and exercise stretching back over 15 years. He specialises in a movement and exercise-based approach with a strong education component and patient-centred focus. Now, Ben set up Cor-Kinetic way back in 2011. And Cor-Kinetic provides educational resources to help health professionals treat their patients better through a modern, evidence-based and active approach to pain and injury. Cor-Kinetic takes a practical and low BS approach to education that looks to unclutter and demystify the often overly complicated world of rehab education. This is done in a learner-focused way that has evolved and adapted to the current global situation. So Ben, via Cor-Kinetic, runs courses, or has run courses, in over 25 countries globally, working with individual healthcare professionals, clinics, health services and hospitals, elite sports teams, pain services and organisations. And so we're obviously delighted to have him with us today. So essentially this episode actually came out of a conversation that Ben and I were having just recently, and we decided actually, rather than continue the conversation, I cut him off and I said, no, let's record this because otherwise we'll lose some great content. But effectively, we were talking about, what do we mean when we're saying we're providing a treatment? And in particular, what do we mean when we're providing a treatment to someone in pain, given what we know about the multimodal, multidisciplinary approach that we need to use when working with someone in pain? So, I mean, I sort of started off as you do. I went and just looked up the definition of the word treatment. And there are a couple of definitions. The one, obviously, the closest to what we're talking about here is the medical terminology. And all right, as massage therapists, we're not medical, but we've spoken before about how if you're working with someone in pain, then we are perhaps having an influence on their health through either the things we do or the things we say. So we perhaps need to be a bit more mindful around that potential for crossover. So in that medical sense, the definition of treatment is the application of medical care to a patient, disease, or symptom. Now, I think we can pull that apart pretty quickly because, Ben, do you ever just treat the symptom?
Well, I mean, many years ago, there was always that trope that people pulled out, didn't they? Don't treat the cause, don't treat the symptom, treat the cause, and all that kind of rubbish. Well, I think if you look at the world through a kind of biomedical lens, that's what treatment means, doesn't it? You're identifying the problem. You're trying to diagnose what that problem is, dependent on your kind of, what you do, who you are. And then once you have that diagnosis, assessment, whatever you want to call it, then you're going to say, I'm going to kind of treat the problem. But in essence, of course, what we all know, and going back to why, people like Engel criticize that type of approach of separating the disease and the illness and these type of things. What we know it is really that you never treat a pathology or a disease. You always treat a person who has that problem. You can't separate these two things. It's dualistic thinking, isn't it? It's creating a false dichotomy, as we would between the brain and the body, or we might between, disease and illness. So I think that we have to see treatment as a broader sense, that we are. I like the word that resonated with me in what you said there, Matt, was the word care. And I think that's more what I think often my role in helping people is about. It's about the role of care. And that encompasses not just treating the problem, but it also involves treating the person and caring for the person who has the problem.
Sometimes treatment, sorry, Ben, sometimes treatment is i- implies that there is an intervention with it. And while now, I think we should be more thinking about the encounter with the person to help, to support them within the care. And I always think treatment just implies too much interventionalism instead of just the encounter between between the therapist and the client.
Am I allowed to swear on the podcast?
You are absolutely allowed to swear on the podcast.
I fucking hate the discussion around interventions. I fucking hate it. It makes my skin crawl. People become so obsessed about the intervention that they do. I'm
Mm,
this. We name
mm,
ourselves after. I'm a
mm.
manual therapist. I'm an exercise therapist. I'm a this. I'm a that.
Yeah.
I'm the other. I really couldn't give a fuck mostly about interventions. I think people get obsessed. Oh
Obsessed.
darling,
Very
we're so
eloquently
obsessed.
said, obsessed.
People get obsessed around interventions, and they get obsessed around mechanisms behind those interventions. And in essence, I think sometimes that almost dehumanizes these things. It takes it away from this process of care and maybe what really makes a difference to someone. And it actually makes it about me, my ability to do a treatment, or it makes it about me and my knowledge of the mechanism. And actually, could you help someone quite effectively without actually knowing a mechanism or using lots of different treatments? And we just get obsessed as therapists of whatever type across the board. We just get obsessed by it. I like the word Anna used there, which is interventionalism. I'm not sure it's a real word, but I
No.
like it. It sounds like something that I would say. But just to reiterate, I think there is an obsession behind interventionalism and identity. And actually, I think that is detrimental often to good discussion and actually sometimes to people's care.
So I think it speaks a lot to the desire for therapists and for clients to have a simple solution to a what we know is an incredibly complex problem, particularly if we're talking pain. It's this. I think the interventionalism is because it's simple, right? Someone comes in with this type of pain, you can do this technique on them to get this outcome. It's neat and tidy. Whereas we know with a lot of pain, that is simply not the case. It's not accurate, and neither do we have the specificity behind the interventions that we perhaps once thought. I mean, I find it interesting that you can go as far as the intervention that is surgery, and actually there's an awful lot of literature now around the fact that we can get results by doing sham surgery. So is the surgery even as specific as once thought? When for me, the idea of the scalpel, you can't get a more specific than a scalpel. Certainly not when compared to what hands are doing when they're touching someone else's skin, fundamentally. So I think perhaps it comes from a desperation to sort of to hang the hat on something simple.
Yeah, no, I agree that and almost if you're offering a service, there is that's why people come to you, don't they? They want their problem solved. Um, but our mindset about how that happens, maybe it is the problem. That if we look at, if we listen to lots of people with chronic pain, for example, some people that I've listened to, that I'm friends with, that are involved in things like patient advocacy, etc. They've kind of told me their stories and said to me that something that was really pivotal for them was things like someone validating their experience, saying that, this is real, your problem is real, you're telling the truth, you're not making it up, etc. And these were pivotal moments, not what someone did to them or made them do. Sometimes I think we misunderstand actually what the problem is, that we're trying to fix, or the solution that we're trying to find. And that, maybe sometimes it's about, again, coming back to that, how do we care for people, and how do we listen to people, and how do we understand people, that provides a much bigger effect, not necessarily on pain always, but much bigger effect on people.
Yeah, Ben, do you think, when you said it's the mindset we need to change, I totally agree. Do you think that it's because the therapist is so much easier to think about the treatment that they want to provide? So they're a therapy-centric approach, because actually we are not trained to be flexible enough within our approach to work with people. We are still in our education system to, again, I use the word intervention centered more than psychologically flexible, to be able to actually change our encounter or our care according to what the person needs at the time. Do you think is that?
Well, we talk about, and if you look at things like ACT, etc., there's this big
Mm,
emphasis on psychological flexibility, isn't there? Your
mm.
ability to, not be always one way of thinking about something, or being able to disassociate yourself from your, inner thoughts and feelings, etc.
Just to jump in there, sorry. So ACT is acceptance and commitment therapy, right?
Yeah. And psychological flexibility is obviously a big part of that, isn't it? It's one of the big building blocks. And I think that we expect people to be psychologically flexible, but therapists aren't always very flexible in the way that they approach things. And maybe that comes back to university, that we're taught algorithmic approaches. Do this test. Once you've done this test, then we go ahead and do this treatment, and this is the outcome. Whereas actually, when you get out into the world of clinic, or you read a lot of research, you actually find that, the same approach often gets quite variable outcomes. And the other point is, if you've got a hammer, then everything's going to be a nail, isn't it? And I do think that we need to be flexible in how we approach people. It might be that one person needs some exercise, or, valued activity. It might be another person does need some hands-on stuff. It might be another person needs to sit and talk for an hour. So, how we approach these things, I think, does have to be variable. But then how does that fit into how people are taught? How does it fit into standardizing healthcare? How does it fit into evidence-based practice? Do you see what I mean? These are
Yeah.
fundamentally things. This is one of the big problems, isn't it? That person-centered care is fundamentally sometimes at odds with evidence-based practice, because we could argue person-centered care is about being flexible. It is about altering your approach. But then evidence-based medicine is about following the evidence and following the data. And somehow we have to reconcile those two things. And I think they are a little bit philosophically at odds with each other.
I have to agree entirely on that. I was on a podcast on which we were a guest a couple of weeks ago. One of the talking points came up around the Cause Health project, and the if I mean, interpreting what you're saying correctly is what indeed, and what they're saying is that evidence based practice, by the strict definition, means that you only apply treatments, if we will, from this, in this context, that have gone through an RCT, that have shown, efficacy, but that when you apply it to that individual in front of you, you either keep applying it until you get the result you're looking for, or they become a non-responder, as opposed to from the other end of the spectrum, kind of going, well, let's look at the person in front of me and maybe the complexity that that person brings to the table, because an RCT by definition controls for complexity. It removes complexity, and yet we're trying to then apply it to a complex human. And one of the sort of points that I mulled over was the fact that in the realm of health, not healthcare providers, but in the realms of sort of people involved in the health of a client, massage therapists, I think, sit very much at the end of appreciating the complexity of the person, whether they realize it or not. The holistic approach that is commonly used in sort of a complementary medicine approach, I think, is what Cause Health are talking about when they want to involve the complexity of the person. What's lacking is the marrying that up with the scientific rigor around decision making and clinical reasoning.
Yeah, yeah.
What do you think? What do you think of that?
Yeah, look, I mean, so what do I think about that? That was fairly deep, Matt. So I'm going to take just a second to mull that over. So look, I think there are real bonuses in that holistic approach, in the, you know, complementary medicine, whatever you want to call it. I don't know what the correct terminology is, what people like to use. And I think there are real benefits in the amount of time that people you know, get to spend with other people, that they get to, you know, build relationships, that they get, you know, time to talk, that there aren't the pressures of diagnosis, that there isn't a healthcare system that's exerting its pressures. Not that there aren't other pressures, but there may be not, you know, these systemic pressures that are involved in things like the NHS, etc. And I think that that's a real bonus. And I think it does. And I actually think that when people do get not let down, I don't know if let down is the right word, but when people don't find what they need from the healthcare system, that's what maybe why they gravitate into that more holistic approach, because it does allow them to get some of the things that they need. And actually, there is nothing wrong with that. I think actually we should have more of that in all realms of healthcare, because I think that's obviously what people are looking for. If you look at research around why people dislike healthcare, it's because no one listens to them. No one takes, you know, no one pays attention to what they have to say. No one really cares about explaining things or whatever. You know, it's about the system itself. You know, and I say that, you know, from no place of judgment. This is from what some of the, you know, qualitative data seems to suggest. And, you know, I think that's really, really important. But then you also, there is this element of, there does have to be some aspect of science within that and within medicine itself. And I think it's about trying to find how we fit these things together, isn't it? And recognize, and this is again what Engel was trying to do here. But I read a brilliant quote from a paper called Engel to Inactivism this week, actually. That my good friend Peter Stilwell sent me over. And we had a little discussion about it, and we both really liked it. And it was kind of Engel would be turning in his grave to see that people had turned the biopsychosocial model into a causative thing. So what is causing your problem? You know, can we find another biopsychosocial driver of your problem? Can we find another mechanism to mediate or moderate, or what other technical language we can use? And would Engel be turning in his grave going, fuck shit, no, you know, this is not what I intended. It totally didn't intend for you guys to take my model and fuck it over by just using it as another biomedical perspective of causation. So I think we have to be careful with that as well. And again, you know, I've chatted with Matt Lowe a little bit about this and the whole Cause Health type of thing. And I really respect what they're doing. Sometimes does it float over a little bit too much into what's causing things? And maybe, again, that doesn't feel like it encompasses quite sometimes what needs to change within the process of having a little bit more of a person focus. But these things are really challenging, and it's up to us to take all of these aspects and maybe be able to wear some different glasses and some different hats that allow us to see the world through other people's lenses and other people's shoes. But fundamentally, again, this is the problem, isn't it? It's taking these perspectives of causation, taking these perspectives of care, taking this perspective of holism or holism or whatever else, and it's bringing it all together. If you think about your average therapist, I have to be a caring person. I have to be an evidence-based practitioner. I have to read evidence. I have to understand it. I have to, have some form of diagnosis and assessment. I have to have some form of, fitting into to the system and the medico-legal aspects of what I've got to do. And in essence, it's really bloody challenging, isn't it? There's so many different parts. And so, I think that we have to be a little bit, I don't know, not too hard on ourselves, but also we have to appreciate that it isn't simple. Maybe there isn't always a simple answer or a simple solution. Maybe there are things that are simpler, but maybe these things aren't really truly simple.
I saw a tweet on my feed, and it's just come back to me now. It was a few days ago, and I cannot think who to attribute it to, and I've no idea how to search Twitter either to even find it. But to all intents and purposes, the tweet was saying, had a client come back in this week after we tried something last week, and they reported phenomenal improvement in their symptoms. They were over the moon. But as a clinician, frankly, I have no idea what happened there.
Yeah,
I
yeah,
celebrated with them, but I have no idea what happened. And it was really refreshing that a clinician. I'm fairly sure it was a physiotherapist, but a clinician in this context was basically like, you know what, stuff happened. It was positive, but I'm not going to claim any kind of that I did something special or particular. Circumstances have meant my client feels better. That is worth celebrating. But I'm not going to say it was I did this and I did that and that was the solution.
yeah. And equally, when people get worse, it isn't something that you've done either. So I think that there is an element always of being fairly neutral when people get better and worse, because at the end of the day, you may not be to blame or to be celebrated for either of them. That's the problem, isn't it? There are so many things that are outside of our control going on at any given time in the complexity of a human being. It's very, very difficult to attribute always exactly what I've done to someone feeling better. Now, look, it would be great, and I'm sure that I've had positive influences. I'm sure I've had negative influences, but I do think there's a bit of we have to be humble with it, which it sounds like that tweet was being, but then also for our own bloody sanity. I think that's really, really important. That if you live every bloody high and low that someone has, for whatever reason, you'd be exhausted. I'm exhausted thinking about it. And sometimes I think that's I think that's a key to navigating all of this as a person, a clinician. That we do have to be a bit step back and say, there could be a whole bunch of reasons why this could have happened, positively or negatively. Can I reflect on that? Could I do things better? Could I do things worse? And so being honest is always I think and it's not being honest to other people, is it? That doesn't really matter. I think it's the honesty with yourself probably that matters the most there.
Yeah, putting it out on Twitter is a nice way of being honest with yourself. It's a bit like writing it down in a diary. It's just a diary that everyone else reads.
Yeah, that's why I don't tend to write the same stuff I might write in my diary.
In your diary there.
Do you have a diary? Oh,
I
God.
do. Jesus. And
Ben
I'm going to
Cormack's
find Anna
diary.
in my bedroom at 3 a.m. in my top drawer trying to find my diary. Could you imagine it? Most of it would just be abusive comments about Adam Meakins, if I'm honest.
Well, so one of the things that I'm sort of keen to try and drill down with you then, whilst we chat today, is so we sort of speak to a lot of different massage therapists and manual therapists who have come from hell, we've all come from a background where we do this thing and that is the treatment and it leads to the outcome. What kind of advice would you be giving someone who is listening to this and going, well, hold on a second. I kind of get that person's really complex, but now you're saying that that complexity is perhaps meaning that my treatment, as I would have seen it, isn't that specific. And actually, maybe that isn't even the treatment. So what advice or how would you position how a therapist ought to view that encounter with their client in terms of, what do you see as the treatment in those encounters? And how can a therapist that's used to, I do X and I get Y as a result, start to reposition that?
Yeah, well, I suppose it's a philosophical stance, isn't it, Matt? It's a shift in your philosophy of how you operate. I have been doing this a while. I'm certainly no spring chicken. And I think along the way, you probably realize that you just don't get these linear responses. I have literally blown on people's necks, and they have woken up the next day in raging pain. Right. And I'm like, I didn't even touch you,
I was going to
and
say,
then
and your wife, when she woke up in raging pain after you'd blown on her neck overnight, was thrilled, I
that,
imagine.
that was an 8-hour blow, though. That was different. Yeah. So that's different. That was tantric. But yeah. So what I mean is metaphorically, you will have literally just, stroked someone's, body part, with a cotton bud, and that level of input has created this real kind of non-linear kind of, response where you've caused someone a lot of pain. And then I've had people in huge amounts of pain, and I've, done quite a lot with them, and I've thought, oh, might have done a bit much here today, and they've woken up the next day and said, I feel fantastic. And then you give people exercises and they make no difference, and then other times you do nothing and people get better. And I think along the way, experience teaches you that it's not just this simple, arithmetic where I just plus 2 and 2 and I get 4. Because essentially, this is, the whole point of dealing with human beings, and this non-linearity. The input and the output don't match each other. I know some people would turn in their graves for discussing inputs and outputs, but I don't mean in that sense. That's the point of non-linearity, isn't it? That your kind of stimulus and response, if you like, rather than an input and output. That might be another way to describe it. Just don't really match up. That there's not a linearity in cause and effect, input, output. How the terminology to me is fairly unimportant. And I think that's important for us to start to appreciate that, it's just not that human beings are not machines. You don't put petrol in it and press the accelerator. We are complex biological organisms that we don't even know that much about. We have lots of different systems and subsystems interacting together. And I like the concept of emergence when it comes to this, because it kind of lets us off the hook a little bit. It lets us say, I have no idea why this has happened. But, when you get a bunch of different systems within a human being, whether that's cardiovascular system, a nervous system, whatever, you have all these different things interacting in ways that are far more biologically complex than we can ever understand. And even if you think about activating a muscle in a biological sense, it's about, and pain as well. It's actually about, things crossing a cell membrane. Biologically, that's an inherently variable process. You are never going to get linearity with that type of process, are you? Do you see what does that make sense?
Oh, it absolutely makes sense. Yeah, and I was going to say, you're never going to get linearity, particularly, you've covered the fact that with this, a menagerie of biological systems, but almost all biological systems, I'm going to hedge my bets, are adaptive. And so from one time frame to another, those systems are even going to change how they
Yeah,
interact with each other
the
in ways
element
we
of temporality, absolutely. So we are adaptive in the long term, and then we are adaptive in a shorter term, in a transient way. And that is the basic premise of, and we are contextual. We are changing according to the context. And to be honest with you, I'm going to divorce myself a little bit from that complexity, because what's the point in even trying to penetrate it? Just accept it.
I often refer with a client when we discuss and when they always want to know because I refer to them as risk factors. Say, so why did it happen this time? I've been running for such a long time. Why happened this time? Because there might have been other risk factors around your life at that time. You just said that you were a little bit more tired. You just said that you're going through a little bit of a tough time. Those are risk factors that increases the risk of you feeling the way you feel, and sometimes that gives them a little bit of um, an understanding that is more than just the physicality and the just linear cause and effect. So I quite
Yeah,
like.
helping people understand. There's two sides to that complexity thing,
Mm,
isn't there? There's the side of it's way too complex to understand type of thing and blow people's heads off, and then there's
y-
the other side where I suppose a gentle introduction to some
yes.
aspect of complexity can often help people just start to and this brings me to the point I think of there does seem to be a real desire for diagnosis within healthcare, right?
Yeah,
From
but the
patients
clients
to
want
everyone else.
them,
Yeah.
Ben. The clients want it. The
But
cli-
I don't believe what people are always searching for is a diagnosis. What they're
Mm,
searching for is an explanation.
yes,
Do you,
yes.
do- and
I
that
agree. I
fundamentally, I
agree.
think those are two different things.
I
That
agree.
people want to be able to rationalize and make sense of their problem. They want some explanation around their problem. It doesn't always have to be a diagnosis or a label. And I think that, and
Yes.
again, this is going to come circular to Matt's point. That for me is part of treatment. It might not be treating pain, but it's treating the person's need for an answer.
Mm,
And sometimes we don't place enough emphasis on our explanatory or our communicatory aspects of what we do. We don't see them as important as the treatment, whereas actually they are probably part of the treatment. And I think that comes full circle to kind of answer Matt's question, because I went around the houses and I think that brings it back quite nicely. But so what we should see as treatment isn't always so look, I've done a little bit of teaching in over the years. And in the beginning, I used to teach lots of kind of exercise technique and do this and do that. And now, almost most of what I teach is having a better understanding of the problem that you're trying to work with. And the reason I do that is because that helps us understand the type of people that get the problem. It helps us understand what the problem is and how it manifests itself and other things that might be associated with that problem. But more than anything else, it helps us help people make sense of their problem. And I think fundamentally that's still why people come to us, because they don't understand, they're worried, they're scared, and they want someone to help them make sense of it as part of that process of care.
Ben, I could not agree more. I love what you said about explanation, not diagnosis, because that's something that I really can see that in clinical practice all the time. They want to know, but you're right. They don't want to know about the diagnosis. They just want to know what's happening to them.
Yeah,
And then,
or sometimes a diagnostic label still needs sense making around it.
yes,
How many people come to me and they'll say, "Well, I've been told this," and my
yes,
first question is always, "What do you understand about that?" And that may be wildly inaccurate. And one
yeah,
of my roles is to help someone understand a little bit more accuracy and reality of what that means. A classic example is the word chronic. People believe that chronic means I've got it forever. It's worse than acute pain. Whereas really it just means it's about time. It's
Yeah.
this label that we latch on to something that's been going on for over 3 months. Suddenly,
yes.
arbitrarily, you could argue it turns into this chronic pain thing from acute pain. And what that means, I have no idea in some elements, but it doesn't inherently mean it's worse. It doesn't mean it's never going to go. But these are some of the things that these are some of the sense making and identities that people attach to it, and helping people redefine that, understand it in a different way can be hugely beneficial.
Yeah, that is, yeah, like you said, is treatment per se. That part, that is treatment per se. That is the intervention, or sorry, the interaction per se.
If I can't, and at the end of the day, we know that pain is a funny beast, and it's very, very difficult to work with and be reliably good at dealing with it. And there's some people out there who say, "Oh, I can do it," and good for you. But at the end of the day, for me, there is also this aspect of helping the person, treating the person. And that isn't just about the technique treating the pain or the outcome measure. And I think that it's hugely beneficial to think about treating the person and caring for the person and their understanding, their mindset, their motivation, their emotion around the problem. As fundamentally, I think that's actually what drives people to seek care.
I mean, and this that speaks beautifully to the quote that I wrote down from the last time we chatted, and we sort of started touching on this, Ben, was that I think you posed the question to me is pain the problem, or is the problem the effect on the client's context? And actually, when people are coming to you, yes, they want to be able to rationalize what's going on, but actually the solution, if you will, that they're probably looking for is actually relevant to the client's context, not necessarily the pain. The pain might feel like it's the cause of the problem.
Yeah, I mean, look, if let's say I'm going to throw something back, I think. So let's say you've had a patient who's had 10, 15 years of pain affecting their lives. It's fundamentally changed the fabric of their existence. They may not work anymore. There may be relationships that have had problems because of that. It may be that their house is set up in a certain way, their relationships work in a certain way to take into account some of these things that have changed in their lives over this time period. And you come along and you take that person's pain away. Is that going to change everything in their life straight away, that one moment? Or are there going to be other things that have developed over time that also may need people to have an effect on? So we like to think, oh my God, we take away the pain, we take away all the problems. So if I took away someone's pain tomorrow, they'd be ready to go back to work the very next day. They'd be ready to engage in society the very next day. And for some people, amazing, maybe they would. For other people, they're going to take a lot of work to get back to where they were pre-pain. And that's not just pain. And again, there's this obsession with pain. Pain changes lives. Pain has a profound effect on the way that people live their lives, what they engage in. And actually, I bet if you took someone's pain away tomorrow, for some of these people, they wouldn't even know what to do.
No, absolutely,
Yeah.
because the pain is taking the pain away doesn't remove the fear that it might come back. It doesn't remove any kinesiophobia. It doesn't remove any context dependent um, issues that they would come across. I'm thinking, social interactions, the fact that they've become known as the person in pain, almost either in their social circles or perhaps in, like you say, returning to work after a long period off.
Well,
Um,
imagine if I said, I'm taking your pain away, but also you've got to go back to work tomorrow.
Yeah.
First thing, 9 o'clock Monday morning.
oh, as someone who has taken, unfortunately, through ill health, significant periods of time off work and had to go through that return to work type process. It's bloody awful. Unfortunately, I've gone through it a couple of times. It never gets better. And the idea of, turning around and you sort of saying, right, problem solved, you're back tomorrow, fucking terrifying.
Well, that would be, wouldn't it? But I've got rid of your pain, so it's okay. What are you moaning about?
Yeah.
So I think this idea of separating, this person just came to me because they're in pain. I'm going to take their pain away. Pain is always a part of it. But if you look at a lot of the research, you will find often pain and function, whatever the fuck function is, often come out quite similarly we're always looking for the one thing that people come for. So if it was 63.2% of people come for pain, 62.4% of people come for disability, we'd say that's the winner. Whereas actually, if you look at it, it's not that case at all. They're very, very similar. And even pain and function are so intertwined. It's almost impossible to separate pain, function, and quality of life, isn't it? In a real sense. You can measure them differently, but they affect each other.
Yeah. Well, and that is, again, that falls back to this issue of strict evidence-based practice, in that it
Exactly.
tries
There
to
you
remove
go.
the complexity from the person.
Yeah.
Uh,
The outcome measure. Let's measure this outcome measure. Let's take your goals. Let's see if they change. That's a success. Whereas actually goals, in the same, people say, well, goals aren't around pain. They're always around function. or some goals are pain related, whereas actually most goals, I think, involve physicality, but they also involve pain during physicality as a limiting factor. So, we do create these arbitrary divisions where actually in reality, these are complex constructs that relate to people contextually. And that's what sometimes my problem with outcome measures is they don't often reflect this. They're great for measuring shit for a research paper. I don't know if they're always great for
In
helping.
clinical practice, yeah,
Yeah,
it's quite.
yeah.
Couldn't agree more.
So, how do we move things forward then? Or do you have any views on how the healthcare provision could move forward with this idea that treatment is perhaps currently too interventional? Obviously, with your physiotherapist hat on, you're going to have a view around how it's approached from a medical
From an
standpoint.
MSK perspective, let's say.
Yes. Whereas I have, as I say, an idea, an opinion, I suppose, about how it's currently dealt with or not dealt with in the sort of vocational massage therapy industry approach. And like I say, I think massage therapists in the traditional sense have an awful lot going for them because complexity seems to be something that is very well understood, except that it's a different type of complexity. We seem to be happier talking about the complexities of the energies in the universe and the fairy dust than we are about the complexities of the biological systems, the philosophy, I suppose, of the approaches that we take and how we boil that down to the person in pain in front of us.
Yeah, look, I mean, I don't think there's anything wrong with looking at things from multiple perspectives. I think that we need that, and I think that holistically there would it would fall flat on its face if it just did the same thing, or if everything just did the same thing, didn't it? So there is some element of differentiation, and I don't think that's always a bad thing. I do think we need some science in there as well, but holistic care shouldn't fall into the trap of copying a more medical model, because I think it would lose what power it does have. But I think that we do. I think it does come back to this education about how we understand, the problem that we're working with first and foremost. Should massage therapy or physio or sports therapy or chiro or osteo, should it start with saying there is a person here, they have come to seek care because of X, Y, and Z. This is how pain influences people's lives and their psyche and their psychology and their habits and their actions. This is what human beings are about. And these are the things that are important for working with a human being before we get into the technicality, before we learn anatomy, before we learn techniques. Whereas I think what happens is you kind of go in, you learn tests, you learn techniques. I learned friction fucking massage, and I learned, whatever. I failed frictions, by the way. I don't even know if they still teach friction. I failed frictions quite badly, as I remember. Anyway.
Which is ironic on the basis that frictions aren't doing anything. How can you fail?
Well, there you go. It was a long time ago, Matt. Anyway, so I think that I think we need to start off by understanding what the problem is, and the problem is one of a human being with a problem, right? And if we can understand it from that perspective and say this is a person, it's bloody shitty having pain, and first and foremost, I am here for this person to say, actually, this is what we're going to try and do by understanding what problem you've had, understanding the impact it's got on your life, understanding a little bit more about what you want from or need from healthcare. And then after that, we're going to fill in the diagnosis side, we're going to fill in the assessment side, we're going to fill in all these other bits. And so I think that we start off philosophically with education and application in the wrong place. That actually we need to start off by saying, these are people, they're people with a problem. let's define what that problem is. Let's see where that what the severity of that problem is versus where they want to get to, and let's see if we can create a link between those two things. At the moment, it's like you start off by learning anatomy, tests, and interventions, and that divorces it a little from the person that's suffering from the problem. Now, I had a conversation on Twitter this morning with someone talking about kind of technology and how technology might help solve some of our problems, and that, you know, that might be something that in the next 30 years might change what happens. Now, one of the, you know, and I'm not discounting that that could happen, but if we approach it in exactly the same way we've approached it in the last 30 years, we've misinterpreted what the problem of back pain is, haven't we? We've thought it's a problem of nerves and discs and facets and whatever other specific structure we can identify and treat. Whereas it might be a bit of a different problem, mightn't it? It might be a problem of a person suffering from a problem, can't do what they want to do, has an effect on them physically, has an effect on them emotionally, you know, motivationally, in terms of their, you know, fear or their apprehension or their confidence, and over time that erodes the person away, and the problem gets worse. And interaction with healthcare doesn't always make that better. We know that, don't we, with the iatrogenic injury? So I think we need to redefine a little bit how we tackle the problem, how we teach the problem. And once we do that, I think maybe that might start to move the needle in it. I don't know whether some people would probably argue that's not forward. I don't know. But I think it maybe needs to move the needle in a different direction, because I'm not sure what's happening at the moment is successful for a lot of people.
Mm. Definitely putting more weight on the subjective assessment, on profiling the person as much as we profile the injury. We seem to wanting to go in and profile the injury, profile the pain, and doing that objective assessment, and we don't spend enough time to actually profiling or understanding the person there. That's why, personally, for me, subjective assessment is an intervention per se. You know,
Yeah,
the right question, the right timing, the right space to understand that person and what they are, what they like, what they do not like, what do they feel, what they will want to achieve. That to me, it's yeah, as I say, it's an intervention per se.
I think that can be really challenging to do in reality, though, as well, because of course clients, patients, they're coming in with an expectation, and usually that expectation is that they receive a treatment. Now you
Correct.
could ask, you know, which comes first, chicken or the egg? Did we set that expectation, or have we pandered to a pre-existing expectation? But I think, you know, from my experience, I have one client who, when they come and see me, they insist they get 60 minutes worth of treatment, and I'm like, well, because I've got to know them now, I understand. But that's the expectation. Not that I'll spend the first 15 minutes working out how the last week's been, or what have they improved, and how have symptoms, you know, changed in any way, and what should I be aware of. More that I've paid for your time. Your time is to provide me a treatment. That is what you do.
but there's an element of the flexibility that we were
Mm.
discussing, isn't there? That, you know, actually that for some people, you know, if you are offering an intervention, I don't know with what I do that I'm particularly offering an intervention. I think sometimes with massage, that's kind of a bit of a crux, isn't it? That's, you know, I've paid for massage. There's a very famous paper called "Why Would I?" It's about chiropractors, and it's called, you know, "Why Would I go to my chiropractor to get an exercise?" And that says it. People go to a chiropractor to get their back cracked. So if someone deviates from that, then it's kind of like, well, I might have well have gone to the
The
fishmonger.
expectations.
Do you see what I mean?
Mhm.
But I think maybe I'm going to kind of latch on to what Anna was talking there. I kind of don't ever do a subjective assessment. I like to call it a clinical conversation.
Yes, yeah, interview.
And I think that for me, it's the more we can make people feel at ease, the more that we can, you know, just interact with them. I actually think the more information we get from them. Does that make sense? I think that what we forget is, let's take this biopsychosocial model with millions of potential pain drivers, although I fucking hate that term, pain driver. You know, this kind of, you know, there's all these different things that could be associated with my pain, or a contributor driver, whatever you want to call it. Well, actually, without a good working relationship with a patient, are you actually ever likely to be able to delve into getting to the crux and the nub of some of these issues? That these things fundamentally stem from relationship and interaction, and making an environment that people feel comfortable to actually turn around and discuss with you.
And that's where I think, as soft tissue therapists, massage therapists, we have a little bit, I think you say, the upper hand,
I
because
agree.
we can transfer that. You call it interview. How did you call it, Ben? Sorry.
I just call it a clinical conversation.
Okay, the clinical conversation. I love that idea. We transfer the clinical conversation on the couch, the
Of course.
subjective assessment on the couch,
Yeah. Yeah.
because that's how person feels much more comfortable to discuss, and you build up this wonderful picture, while at the same time they feel good, they get what they were expecting, and then slowly changing those expectations. Because Matt, I couldn't agree more with you. Just getting into a room with a couch in front of us, there is the expectation. Sometimes the expectations comes hinder some approaches which we know that could be more beneficial for the client at the time. So I totally sympathize with that when they say, actually, I pay you for the 60-minute massage, because that's what they're expecting. And that's where we need to be much clear. Sorry, this is going to be a tangent, but much clearer when they call to us. What are you coming to us for? Are you coming to me for receiving a massage? That's fine. For feeling good? That
Yeah.
is fine.
Yeah.
That's what I get. But if you're coming to me because you have, let's say, lower back pain, then my approach is, and is, we discuss, we have the, I'm going to pinch that, the clinical conversation.
I've already
With
trademarked it, Anna.
have you?
In 37
TM,
different countries.
I'm sure, the assessment and the treatment. Sometimes there will be treatment and this manual treatment and the do massage and so on, so on. So I think we need to be clearer on our expectations. But I sympathize, Matt, with you very much indeed.
Yeah, I mean, I was
Mm.
listening at the clinical conversation more than the subjective. Again, if we're looking at that, and I really like that approach, because essentially what you were speaking to there, Ben, I think, is building trust. And that trust to share some of the information that might otherwise feel awkward and alien for the patient to share with you, but also building trust that the questions you're asking and the information you're seeking is relevant to their problem. And I was listening to an older episode of the back pain podcast recently, and I think it was Rob who was talking about the fact that he had a client. They were talking cauda equina symptoms. He asked the cauda equina symptom questions, which obviously they're talking about genital function, toilet
Mm.
function, sensitivity, around those areas. And at the time, the client said, no, I haven't got any of those issues. And then it was only later that the client actually apparently rang him back and said,
Yeah.
actually, yeah, I did. It's just at the time it didn't feel the right environment to
Yeah.
those
Yeah.
questions. He has
Absolutely.
to understand the context, and yeah, I think it comes back to building that trust so that you can have the conversation, so you can find out more about the person, so that you can direct your treatment. I'm going to use that word because that's the word we're
Oh,
talking about.
yeah. Absolutely. Yeah. Look, so when I talk about, I think trust is built on many levels. So do you trust? How quickly does it take for sometimes us to build, an idea of whether someone is interested in us being in a room, or whether we are the focus of someone's attention, or whether, a great example, you go out with a friend and they're fiddling around on their iPhone, and you might just think, oh, well, you can piss off today then. Do you know what I mean? Because you're meant to be out together and all they're doing is messing about with their phone, and it might be habitual or whatever. And so I just think that there's very, very small things maybe that we have to be aware of and cognizant of, quite quickly to make people feel like they're an environment that is there to help them. Whereas, and this is people's criticisms, not my criticism. How many times have people gone into consultants' rooms and they feel like they're, they're rushed in there, rushed out of there, they're, you know, almost an inconvenience, you know, etc. And it, for me, that's one of the biggest complaints that I hear about these type of things. So I suppose that, you know, again, trust is built on many levels. You're not, well, you know, I don't want to know what this person secretly did at the weekend, you know, but I do want them to feel like there is an environment that they can communicate in safely. And I think that we have to do that quite quickly and make that happen quite quickly. I think that's important. When we talk about trust, it's not the type of trust, I want you to be the best man at my wedding. But you know, it's the type of trust where you need to trust me and respect me enough that we are partners to get this shit done.
Yeah.
So, respectful of your time today, Ben. Obviously, well, I'm assuming you've listened to every episode we've ever produced. But just
twice, Matt, twice.
in case you haven't, I thought I'd give you a gentle reminder that and to put you on the spot, because actually I didn't preempt this at all. We like to give our listeners, our audience, a bit of what we call theory to practice. Okay, so we try and pull out 3 key themes or ideas that could be put into practice straight away.
Yeah.
And so while I waffle for a couple of seconds, maybe you can think of 3 key takeaways that you would suggest that, you know, particularly from a massage soft tissue therapy perspective, a therapist could do to move their needle a little bit when it comes to considering what the treatment is, considering the complexity of the person in front of them, with the evidence base, perhaps. Other than obviously what I would say would be the fourth key point, which was obviously come and attend your therapeutic movement and exercise course on the 5th and 6th of February 2022 down in Exeter. I mean, that goes without saying, right?
Oh, well, of course. So you didn't even need to say it, but you did because it went without saying. But yeah, I'm glad you said it.
So that aside, what would be your sort of 3, you know, theory to practice takeaways?
Yeah, I think that we certainly have to place less emphasis on treatment and the techniques and the skills and the tricks and the tips. So people go on courses to find that one missing technique that's going to fix everyone with back pain. Well, throw the idea that that exists out of the window, because I guarantee you that technique will make as many people worse as it will make better. So I think there's the idea that there's always something special out there that we can add to our toolbox. You know, I think that the most special thing that we can add to our toolbox is maybe changing our philosophy of how we work and thinking a little bit more about placing the person as the center, or the person as the emphasis in this, rather than placing the technique or the intervention as the emphasis. And I actually think that probably will have an effect on outcomes, and that could be financial outcomes because people might like you more. It could be, outcomes on in a myriad of different ways, satisfaction, etc. So I think that's one. I think 2, and you have put me on, you've ambushed me here, Matt.
I have slightly ambushed you. I should have given you warning.
Yeah, you should have given me a little bit of warning. I think another take home is that the way that we communicate and help people make sense of their problem is really important. I think one of the big mistakes is that people just give reasons. So, oh my God, you've got back pain because your hip flexor's tight and I'm going to massage it and you're going to feel better. Whereas actually, I think that shows a profound, lack of knowledge about back pain, about what back pain actually is. So if you are going to treat back pain, foot pain, neck pain, you need to have an understanding, regardless of who you are, your scope of practice. You need to have an understanding of what these problems are about, what the guidelines say, what are likely potential causes, what are some risk factors. Because you could go and massage the hell out of someone, but they have all these other things going on that you could influence by good advice, by sense making, and you've missed the trick. Do you see what I mean? You've missed the trick there, and it might make your intervention that you are skilled and trained in less effective. So I think having knowledge a little, you don't need to be a PhD in back pain to help people with back pain. But I do think you probably need to know a little bit more about some of the rudimentary things, what we do know, what we don't know, and again, help people make sense of their problem and provide a little bit of an explanation, because that's often what people are searching for. So that will be 2.
I was going to say, do you want me to, agree that 2's enough? Because they're 2 very detailed ones.
Yeah. Well, just based into that, see communication as an intervention, sort of. And in that sense, what I mean by that is, do I think that communication on its own, I'm going to talk your pain away? Probably not. But do I think being able to communicate with people better, being able to cultivate trust, being able to make people more confident in you and them, is that going to help you? Yes. See it as another intervention if that's what motivates you to get better at it.
Perfect. Look at that.
That's
3 key
all
points.
my biases ticked.
Wonderful. Well, so other than obviously in Exeter on the 5th and 6th of February next year for your fabulous 2-day course, what else are you up to in the short-ish term?
Well,
what's coming up?
Tomorrow, I'm off to Norway for my first teaching trip in 20 months.
Wow.
People probably don't know very much about my career, but it was very much involved traveling the world, teaching in, pretty much every country that would let me, which is quite a few actually. And so I'm getting back to that. Next year, I've got, starting to really fill up the diary. I'm going back to, I think the week after Exeter, I'm off to Finland. Got some dates in the US. Got some stuff going on in Italy and in France and in Ireland and a few conferences. That's what I'm actually really looking forward to. I love the buzz around conferences. And I think I've got one at the beginning of January, then another one in February, another one in March, and then one in, so I've already got 5 or 6 conferences booked in, and I love the buzz and I love speaking to people about this stuff. And so, I feel like things slowly feel like they're getting back to where they were. Were there some negative aspects that I didn't see my family enough and I was absolutely knackered? Yes. Am I going to try and avoid those mistakes? Yes. Am I going to manage it? Probably not. But, I am looking forward to getting back to and really, I'm not the smartest cookie in the world, but I do love to talk. And I feel that talking is probably my one skill set in this world. And hopefully I'm going to get to do it a little bit more.
Fantastic. And eloquently as well.
Yeah, very
As
good.
eloquently as you get for a Southeast London boy.
Well, that's been absolutely fantastic, Ben. I think, a cracking episode. So thank you very, very much for your time. And we'll look forward to seeing you really soon.
Absolutely. Thanks for having me on, guys.
Bye now.
Ciao.